Prashant sir, session over to you.
Thank you. Good afternoon, doctors.
Good afternoon.
Welcome to this experience sharing program on managing PPH, case studies from the labor room. This program, doctors, as you know, is brought by Hetero Healthcare. Hetero Healthcare is an innovative pharmaceutical company with 25 years of excellence and 36 state-of-art manufacturing facilities. Hetero Healthcare has 300 plus products in portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are the largest closely held pharmaceutical company. Hetero Healthcare has amongst the largest manufacturers of ARV, APIs, and FDFs in the world, and has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare, a 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Hetero Healthcare, the pioneering antivirus, offered oseltamivir, favipiravir, and remdesivir to the patient, because of which in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, experience sharing program on managing PPH. We have got Honorable Speaker Dr. Gopal Chavan with us. Welcome, Dr. Chavan.
Thank
Dr.
you.
Gopal Chavan is founder and director of Rainbow Women's Super Specialty Hospital, Nanded. Sir is MBBS from SVN GMC Yavatmal and DGO from GMC Miraj. Sir has PGDHM from Annamalai University, Tamil Nadu. Fellowship in Infertility from Madhudeep Infertility Center, Gujarat. Has been Assistant Lecturer Department of OBGY GMC Nanded for 1 year. Chairperson High Risk Pregnancy Committee Nanded 2024. Lifetime Award Mahatma Kabir Samta Parishad in 2022. And area of interest has been hypertensive disorders in pregnancy and high-risk pregnancy. With this brief introduction, I welcome Dr. Gopal Chavan. Sir, I'll start the presentation.
Good evening to all of you. Just we can discuss first upon what is the postpartum hemorrhage. Postpartum hemorrhage is any amount of bleeding after the delivery of the baby, which clinically affects the general condition of the patient. That is decrease in the blood pressure and increase in the pulse rate. It labeled as a postpartum hemorrhage. In quantity, loss of at least 500 cc of blood following vaginal delivery and around 1 liter after cesarean section. It is labeled as a postpartum hemorrhage. PPH is a common and can occur even in who are not at risk mother. It is a leading cause of maternal mortality in low-income countries and in the primary cause of nearly 1/4 of all maternal deaths occur globally due to the postpartum hemorrhage. PPH is a leading cause for the maternal mortality, accounting for about 35% of all maternal deaths are due to the postpartum hemorrhage. Maternal MMR, that is maternal mortality rate in developing countries, was 240 per lakh live births compared to the 16 in developed countries. Globally, per year, 14 million women suffers from PPH. Incidence of PPH is reported as around 2 to 4% after vaginal delivery and around 6% after cesarean section. In India, PPH incidence in India is 38% of maternal deaths are due to the postpartum hemorrhage, and around 25% global deaths take place in India, and 2/3 of these attribute to the postpartum hemorrhage. India has unexpectedly high maternal death rate, that is 540 per lakh live births. What is etiology of the postpartum hemorrhage? Etiology for this, the 4 T's are very 4 T's factors are responsible for the postpartum hemorrhage. First and foremost is a tone of the uterus. Second is a trauma of the genital tract. Third is a thrombin and a coagulation factor deficiency. And fourth T is a tissue, that means retention of any placental beads, clots, or abnormal placenta. Main cause 80% of the PPH is due to the atonicity of the uterus. In in atonic uterus, there is an inability of the uterus to contract the myometrium, which may lead to the continuous bleeding. What are clinical findings of the in postpartum hemorrhage? In clinical findings, the first and foremost sign is the maternal tachycardia, followed by the hypotensions, then abdominal tenderness, then circulatory collapse is there. There is increase in the abdominal girth, and there is active vaginal bleeding is seen in the postpartum hemorrhage. How will you diagnose? Diagnosing of the PPH is a very crucial steps for the management of the postpartum hemorrhage. Whenever you suspect any patients which is a high risk pregnancy, or you have to suppose to patients may lie in postpartum hemorrhage, you should aware of this all these complications or consequences occurs during delivery or cesarean sections. You have to initially, after delivery of the baby, you have to initially evaluate the general condition of the patients. That means you have to see the vitals of the patients, her pulse rate, blood pressures, and amount of the blood loss. You have examine the you have after this you have examine the patient. You have to see the tone of the uterus. Then you have explore the vaginal. If you are suspecting tone of the uterus is good, then you have to look for the vaginal and cervical lacerations or explorations. You have to then manual examination of the retain any. You have to do the per vaginal examinations, and you have to see the what anything is anything is left in the uterine cavity, or you have to check whether it is a cervical or vaginal wall tear or lateral vaginal wall tear. And then you have to do the basic investigation. Minimum basic investigations are complete blood profile, blood group of the patients, and coagulation study. In CBC, you have to look for the hemoglobin count and platelets count. You then approach toward the postpartum hemorrhage patient. You have to first and foremost findings. You have to look for the tone of the uterus. You have to in atonicity of the uterus. When you have examined the patients, there is a uterus feels like a bogey and soft, and you have to see for the you have to look for the her blood pressure and counts. You have to send her complete blood count, coagulation profile, serum electrolytes. You have to start the uterotonic. If you suspect there is a atonic uterus, you have to start the sorry uterotonics, that is oxytocin or carbetocin or methyl ergometrin, whenever which is available to you. Then you have to see for the tear or trauma. You have to see for the any retained placental beat, and you have to do the basics coagulopathic profile, that is bleeding time, clotting time, PT-INRs, and liver function test, and electrolytes. How will you then there is a newer drug which is available in the market is a carbetocin. Carbetocin is a carbetocin. There is the uses of carbetocin. We have here we have compared the uses of carbetocin for the oxytocin. Oxytocin is the most commonly drug which is used traditionally since last many of decades. But recently carbetocin is available in the market, which is which is stored at a room temperature, and it is convenient while convenient in the vial preparation. It is stable at the room temperature. Her half life has half life of around 20, half shelf life of 24 months at 30 degrees Celsius. There is no requirement of cold chain storage and logistic, and it is provided in the vial as compared to carbetocin, oxytocin, and ergot alkaloids. It should be kept in the refrigerator to avoid the degradation. And previous formulation of carbetocin should be stored between 2 and 8 degrees Celsius, but recent formulation there is no need. And then what is the use when you have to use the uterotonic drug, which molecule, which drug should be used, and how to use it is very important for the postpartum hemorrhage. Then the timing of the administrations of the drug, that is at the crowning of the baby's head, at the delivery of the anterior shoulder, or at the end of the second stage of labor. Then when it is prophylactically used, if you suspect the any patients which has which may land up into the PPH. That is the case in which we have to suspend the PPH. Then you should prophylactically use the active management of do the active management of PPH. The molecules which are used for uterotonic drugs are oxytocin, carbetocin, ergometrin, symptometrin, misoprostol, and carboprostol. What is Carbetocin? Carbetocin is the next generation drug for the postpartum hemorrhage management. It is a synthetic, long-acting drug. Which is analog of the oxytocin. It has only therapeutic indication. It is used as a treatment of postpartum hemorrhage due to the uterine atonicity. Uh, one vial contains 1 ml of solution of this injection, that is 100 microgram of injection. Carbetocin was created by making several modifications to the oxytocin structure. It prolongs the half-life, and it reduces the enzymatic degradation. Then mechanism of action of the carbetocin. Carbetocin, it blockage, it binds the receptor binding, triggers activation of phospholipase C, and it leads to the generation of the second messenger IP3 and diacylo glycerol. Then IP3 induces the release of free calcium from the intracellular store, and binding of calcium to calmodulin. Calmodulin stimulates the uterine smooth muscle contraction by activation of myosin light chain kinase. A single intravenous dose of carbetocin 100 microgram administered after the delivery of the baby is sufficient to maintain the adequate uterine contraction, preventing uterine atony and excessive bleeding with efficacy compared to the hours of the oxytocin infusion. Then what are the carbetocin clinical evidences? How will you the efficacy and safety of carbetocin versus oxytocin? Then carbetocin is non-inferior to the oxytocin as per WHO champion trial. Carbetocin decreases the need for the uterotonic agent versus oxytocin. It is then single dose carbetocin versus continuous infusion of oxytocin. Comparison of carbetocin versus oxytocin with respect to the reduction in the blood loss and need for the intervention, and efficacy and safety of carbetocin versus symptometry, and efficacy and safety of carbetocin versus misoprostol plus oxytocin. We will differentiate the oxytocin and carbetocin, because oxytocin is very cheap drug, easily available, and we can use since last decades. We have just described the oxytocin and carbetocin. Oxytocin is a synthetic cyclic peptide from the naturally occurring posterior pituitary hormones. It directly binds to the oxytocin receptors in the uterine myometrium. It stimulates the contraction of the uterine smooth muscles by increasing the permeability of the uterine myofibrils. Carbetocin, it is a long-acting synthetic analog of the oxytocins with agonistic property. It binds to the oxytocin receptors in the uterine smooth muscles, it resulting in the rhythmic contraction that leads to the increased frequency of exciting contraction and increased uterine tone. The pharmacokinetics of oxytocin is almost intravenous immediate action with peak concentrations within after 30 minutes. As compared to carbetocin, it has IV sustained uterine contraction within 2 minutes, it lasting for about around 6 minutes, and it is followed by the rhythmic contraction for 60 minutes. intramuscular, when you have given intramuscular injection, IM is a slower onset of action, taking 3 to 6, 7 minutes of oxytocin, but it produces the longer lasting effect around 1 hour. In carbetocin's intramuscular action is sustained uterine contraction lasting for about around 10 to 11 minutes and rhythmic contraction for around 2 hours. Main side effects, main drawback of the oxytocin is storage and transport, because oxytocin requires protection from light and it is stored at 2 to 8 degrees Celsius continuously to preserve its activity. As compared to carbetocin is stored up to the 30 degrees Celsius temperature, so there is no need of any cold chain maintain or any refrigeration for the carbetocin use. As compared to oxytocin and carbetocin, oxytocin may be used can be used in the induction of labor, augmentation of labor. But carbetocin, it is not used in the induction and augmentation of the labor. The champion trial, that is carbetocin is a non-inferior to oxytocin. WHO champion trial recommends that carbetocin hemorrhage prevention. In this, we have to see the largest clinical trial in the prevention of the postpartum hemorrhage. It is trial conducted by the WHO Department of Reproductive Health and Research Center. In this, we have to design the study. Non-inferiorly double-blind randomized trial was done to compare the effectiveness and safety of heat-stable carbetocin versus oxytocin in the prevention of the postpartum hemorrhage after cesarean sections and vaginal birth. In this study, we have done, WHO has done around 30,000 women across 10 countries, including India, and the result was the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic drugs, the proportion of women with blood loss of at least 1000 ml. Carbetocin efficacy is around 14.5%, and in oxytocin is 14.4%. The frequency of blood loss by at least 500 ml or the use of additional uterotonic agents with carbetocin was proven to be non-inferior versus oxytocin. The use of additional uterotonic agent interventions to stop bleeding and adverse effects did not differ significantly between the two groups. Then guidelines for the recognize the benefits of carbetocin for preventing the uterine atony. In WHO recommending body in 2018, guidelines for the PPH prophylaxis drug is only following drugs are used, that is oxytocin, carbetocin, misoprostol, carbetazole, misoprostol, ergometrin, and oxytocin and ergometrin fixed dose combination. The SOCG 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 Canada advised carbetocin 100 microgram IV bolus, recommends the use of the for prevention of the PPH. FIGO advised carbetocin is one of the recommendations for the PPH management. Germany, Austria, Swiss body, and FCOG France in 2015, carbetocin is on providing non-inferiority to oxytocins. My experience with carbetocin is a smarter, superior, and safer choice in postpartum hemorrhage management. We have compared the normal delivery patient and cesarean patient patients. In last 2024, we have around 200 primary data patients compared heat stable carbetocin with oxytocin for active third stage of labor. Carbetocin was found superior to the oxytocin, showing statistically significant reduction in PPH incidence and decreased need for additional uterotonic drugs. The summary of the benefits for normal delivery is a carbetocin is a synthetic oxytocin analog with a longer half-life compared to oxytocin. A single dose provides a longer period of sustained uterine contractions, potentially reducing the need for repeat injections or infusion. It is used in the simplified manner because it is a single dose treatment. Carbetocin simplifies the management of the third stage of labor, and it reduces the workload of nurses compared to the oxytocin because oxytocin's infusion required more time and monitoring, and oxytocin requires continued infusion. And major advantages is it is a heat stable formulation. The development of heat stable carbetocin makes it particularly valuable in low and middle income countries like our country, and it may reduce the work and where maintenance of cold chain for storage and transport is a significant challenge. It reduces the postpartum hemorrhage and additional interventions as compared to the oxytocin. Studies show that carbetocin is comparable to or potentially more effective than oxytocin in reducing the blood loss and need for the additional uterotonics, especially when compared to the misoprostol. Then my study our case studies in cesarean sections for the high risk pregnancy. High risk pregnancy means the when we are suspecting the high risk pregnancy cases, that is big size babies, multiple pregnancy with the PIH, pregnancy with the anemia, pregnancy with the heart disease, pregnancy with the uh, abruption, antepartum hemorrhage, pregnancy with placenta previa. In this case, the prospective case control study was conducted in India in our center. Also, women with high risk factors such as multiple pregnancy, previous cesarean section, placenta previa, who were undergoing a cesarean section. Our group received a single dose of 100 microgram carbetocin, while the other received a 20 international unit intravascular infusion of oxytocin over 60 minutes. Results shows that carbetocin significantly reduces the need of additional uterotonic drugs, that is 13% versus 43% in the oxytocin group. It also leads to less intraoperative blood loss and maintain better uterine tone both during and after surgery. The carbetocin group maintained the better hemodynamic stability, experiencing fewer blood pressure fluctuation than the carbetocin group. In addition to teen pregnancy, cesarean delivery, in retrospective study in Taiwan also investigated the effect of adding carbetocin to standard uterine regime for cesarean section in women with multiple gestations have very good outcome of mother. Hello. Hello.
You're telling something? We'll go to the panel question.
Thank you very much for your valuable and kind attention.
Sir, how long have you been using carbetocin?
Yes, sir. Yes, sir.
How long has you been using carbetocin?
We are using since last 2 years, sir.
2 years. And
Yeah.
you mostly use intravenous or
Previously,
intramuscular?
we have started my practice is started around in 2015. As when we are after using the carbetocins, the incidence of the postpartum hemorrhage is comparatively less very less as compared to previous.
Oxytocin. How you use it, sir? Intramuscular or intravenous?
We have routinely used the IV.
IV. And you use it in both cesarean as well as normal delivery?
Normal delivery. We are, because our hospital is a tertiary care hospital, tertiary center. We are dealing with many high risk patients. So our protocol is we routinely use the compulsory use carbetocin.
Okay. And any side effects you have seen in your practice?
No, sir. Comparatively, side hypertensions and tachycardia are more common with the oxytocins, but in carbetocin, the side effects and adverse effects are very less as compared to the oxytocin.
Oxytocin. Now coming to some of the question, what is the patient profile where doctors can anticipate a PPH?
Uh, Patient profile where we can pregnancy, high risk pregnancy patient, that is PIH, abruption, multiple gestation, twin pregnancy, previous LSCS, over distended polyhydramnios.
Even fibroids can precipitate.
Even any uterine anomaly. Any uterine anomaly also, fibroids also, unicorn uterus also precipitate.
What about diabetes, sir? Gestational diabetes?
Gestational diabetes also causes a postpartum hemorrhage. Hello, because in gestational diabetes there is a polyhydramnia. There is many of the gestational diabetes is commonly associated with the polyhydramnias.
Okay.
Hmm.
In which patient would specifically use carbetocin over oxytocin for management of PPH?
Yes, don't understand, sir. What we are telling?
In which patient
Huh.
you prefer carbetocin over oxytocin?
We routinely use for high risk pregnancy patient. It's oxytocin, carbetocin is more beneficial than the where we are suspecting the chances of postpartum hemorrhage. Where we are anticipating, we are postpartum chances of PPH is more. So we prefer the use of carbetocin as compared to the
Oxytocin. Can we use carbetocin in case of retained placenta? तुम्ही कधी वापरले sir in case of retained placenta?
retained placenta. You can use retained placenta in carbetocin because carbetocin intravenously venous मध्ये जर आपलं placental vein मध्ये जर टाकलं IV bolus, so there is a early chances of separation of the placenta as compared to use of oxytocin.
So you had any occasion to use?
No, till not.
And in case of Rh negative mothers?
You can arrange individual, you can use routinely. There is no side effect or any adverse effect seen or any incompatibility.
Contraindication. Sir, we use oxytocin, we normally use for induction, second stage, etc.
Okay.
If oxytocin is used for induction, can you use carbetocin for prevention of PPH?
Yes, if you are using the oxytocin for induction of labor, then carbetocin is used, but the comparative outcome of the carbetocin is chances of PPH is more when we are using the oxytocin for induction.
Okay. In which case you generally prefer IV, you said. But is there a place for IM?
No, we generally prepare the IV. IV is intravenous route is more beneficial than the intramuscular route.
If the patient is not responding adequately with carbetocin, which additional neutrotonics would you use?
We are using the misoprostol and which is prostaglandin PG1, and we can use the carboprost injection. It may be it is a PGF2 alpha. It is used directly intramyometrium or intramuscular. But the adverse effect associated with carboprost is more.
Yes. Prostaglandin related side effect. You cannot use it in asthmatics.
Asthmatic or any LRT.
People can get loose stools also no, with this prostaglandins.
Shivering, loose stools, fever.
What are the advantages of oxytocin over other uterotonics?
Oxytocin or other uterotonics?
Carbetocin, sorry. What are the advantages of carbetocin over other uterotonics?
Advantage of carbetocin is it is main for our country. It is there is no need of require cold chain maintenance or cold chain temperature. There is no need for the temperature maintenance first and foremost. Second, it is given in a single dose.
Okay.
There is no need of continuous infusion or monitoring. Okay, and as compared to the cost of the drug, uh, 20 unit costing around 20 unit of pitocin costing around 100 rupees, but you can see 300 to 400 cost of this carbetocin. Sir.
Should carbetocin be kept as reserve drug or should be used as first line?
It is first line drug, first line drug.
What is the role of anesthetist vis-a-vis gynecologist for prevention of PPH?
Anesthetist, what is the?
Anesthetist plays any role in choosing the drug for PPH?
Yes. Anesthetist's role is very important. When we are suspecting the any incidents of PPH has occur, anesthesia role is very crucial for the managing the case of PPH, because general condition and vitals are managed by anesthetist, and he should help us to he or she should help in management of the PPH, because it is PPH is it requires a team of the anesthetists, gynecologists, staff, and nurses.
To conclude, what is your take-home message for audience?
Take-home message is the use of the carbetocin is very beneficial to the patient. It avoids many complications of the postpartum hemorrhage is the main complications of the pregnancy delivery. It avoids it has many advantage over the other uterotonic drugs, that is oxytocins and misoprostol. So I request or I recommend the use of the carbetocin as a first line drug for the choice of the PPH.
Thank you, doctor. Thank you so much. Thanks for your experience.
Thank you.
Thank you.
Thank you.
Very nice session. Thank you so much. And I thank all the doctors who took time from their schedule and attended this. Thank you, marketing and sales team of Hitro. Thanks, Bivas. Thanks, Nagadevi. Thank you, sir. Wish you तुम्ही log out करू शकतात. Wish you a very pleasant evening and happy Diwali, sir.
Thank you.
We can log out, huh?
Okay.
Oh,
Thank you, sir. Thank you so much.
Log out. Thank you.
ते पेशंटला मध्ये हे केलं ना मध्ये नेऊन ठेवलं
साखरे सर काय म्हणले?
सागरे सर यायला म्हणले
आवाज सर काय म्हणले?
आवडते सर बसलेत मध्येच
दिले का? लॉग आउट करते का?
Session is over, na Bivas?
yes.
Yeah,
You can
Nagadevi, you
close
can
session.
stop recording.
Close the session.
Yeah, I can stop. Yeah, it's done.
Thank you, Nagadevi.
Thank you,
Thank
sir.
you, sir. Bye, Bivas. Bye, sir.
Bye, Nagadevi.
Bye.
Bye, sir.